Okay, guys, welcome back. We're picking up with part two here. There's part one to the financial environment. Make sure to go out on the D2L page and view that if you're just now tuning in. So, we're going to pick up here talking about managed care plans, and this will finish us out through the lecture. We'll talk about managed care plans, some uh, coding points of interest, and then end with the Affordable Care Act. So, managed care plans. Really how they're set up and work, or how they're set up and how they work is a combination of taking healthcare services and the insurance function into really a singular organization. We'll go ahead and get the rest of the information out here. So their purpose really and how they come about is because we were based on or doing this cost-based reimbursement. We had to figure out a way to really control cost. So managed care plans put a lot of mechanisms in place to work to control costs, and we have things like reimbursement tools, financial incentives, some management tools, and we'll get into all that throughout this half of the lecture talking about managed care plans. So managed care plans, let's go ahead again, let me get the information out here. Managed care plans, how they're set up and how they work and their purpose is to combine the financing and the delivery system. So patients are enrolled in a managed care plan on what's considered a prepaid basis with a more defined benefit package that includes services like your primary care, your preventive care services, and then patients can either go out and select themselves, or they are assigned a primary care provider, or you may hear this called a PCP, but it's a primary care provider. And what that primary care provider does is they act like a gatekeeper to coordinate more specialty type cares and hospital cares that the patient needs. So you have somebody almost standing between the patient and maybe a specialty type, like if they need an ortho doctor, you have to go through your primary care provider first, who will then acting as the gatekeeper, will make the referral out to that ortho specialist. So utilization and clinical practice are reviewed here to work to contain cost. So we're working to bring down cost, increase efficiency, while giving incentives to improve health status for the patient. So providers in this model and in managed care and those who accept managed care plans are paid on a capitation basis. So remember, we just talked about capitation basis a little while ago. That's how they're traditionally paid, but can be paid on a fee-for-service basis. So under managed care plans, we have a contractual relationship for more designated services, and this spans across the continuum from primary all the way down to tertiary care. So we've created these these provider networks where these companies have went out and contracted with different types of hospitals, different types of providers who have entered a contract with the managed care company saying, we will accept your terms and we will accept your patients into our facility or into our practice. Now, a couple of points of criteria for members of a managed care organization. They need to select, like we said, a primary care provider that will act as that gatekeeper, and they will have to see primary care providers to receive referrals out to more specialty type cares. The example I gave was ortho. If you have cardiovascular issues, still have to go see your primary care provider first to be able to get that referral out to a cardiovascular provider or cardiovascular specialist. And they have a couple of points to work on cost control. So they have provider utilization reviews or retrospective reviews. They use capitation. And again, because you have the primary care provider who acts as the gatekeeper, members who enroll in a managed care plan will need some type of prior authorization before they can go out and receive services. So there are some incentives to encourage the appropriate use of these healthcare services that patients will go out and receive. But why do we have an incentive for preventive care? And it's really to emphasize keeping your subscribers or keeping your enrollees healthy so that you can ultimately reduce the use of services. You know, we want to decrease utilization, which will increase and maximize reimbursement, maximize and reimburse and maximize our revenue coming into the organization. So if we have, let's say, for example, we have two treatments that are very similar, we're going to push for the lower cost one, right? Because our job as a business is to find the funds to support our business operations. So if we have two treatments that are very similar, we're going to push for the lower one. And we have utilization review on here, and utilization review is really more of a fancy term for a process that's used by these managed care plans to determine whether a specific medical service or maybe a certain type of surgery is appropriate or it's called medically warranted for the patient. So for example, let's say you as a patient, you have some really severe neck pain. And you've done your research, you've went out, you've looked, and you've got a great idea about how you're going to alleviate this pain, and it's through this new cervical disc surgery that you've read about on the internet. So you've went out, you're trying to be proactive as a patient, and you really feel like by getting this surgery, you're going to be relieved of your neck pain. So you go in, you talk to your primary care provider about it, and they're very familiar with the procedure, but that particular practice or that particular surgery is not going to be regarded as just absolutely necessary for you as a patient for your condition, for your neck pain that you're having. So a medical review specialist is going to be brought in to make that final decision about whether or not your insurance is going to cover the cost of that operation. And they may decide to cover it, but they may decide not to. So that's all, that goes back to utilization review. Is the service needed or medically warranted for that particular patient and their particular disease or their particular need at the time? So this was kind of the setup for managed care plans. Before we get into the individual type of plans, I wanted to give you just a little bit background on managed care plans, how they function, how they came about, before we get into the individual components of, like your HMOs, your PPOs, and your POS type plans. So what I have here is your continuum of managed care, and this is really to show you how the plans relate to each other, and where they kind of sit on this scale from the more capitated reimbursement method. Remember, we said that can be found under managed care plans, but you can also see fee-for-service reimbursement methods under managed care plans, and to kind of show you where everything sits. So you have the three that we're going to talk about, which is your HMOs, your point of service or your POSs, and then your PPOs, your preferred provider organizations. So HMOs, probably the most strict. They are the least expensive, but patients, you can see, have the less amount of choice under HMOs because they do run on a capitated reimbursement method. So you've had to have had a panel of physicians say that they will accept this capitated rate. And then under that, your next least restrictive one would be your point of service, and then under that would be your PPO. So you can see as you start moving down more towards the spectrum with your preferred provider organization, you have, they may be more expensive, but you get a little bit more choice on who you want to go see, and it's not so restricted. So that's really how I set this up to talk about the three types of plans that we're going to be concerned with here. So HMOs, health maintenance organizations, PPOs, preferred provider organizations, and then point of service. And remember too, HMOs most restrictive, then you have point of service as your second least restrictive, and then your overall least restrictive is going to be your preferred provider organization. So HMOs, health maintenance organizations, they're probably the oldest type of managed care plan out there. They are the most restrictive, and the most restrictive in this model is going to be the staff. So we see a shift to the most common, which is your IPAs. Now let me back up a second. Staff model is going to be where the facilities are owned and the physicians are employed by the health maintenance organization. As we kind of move down the scale, as we see here, we move from this most restrictive type of the staff model. You have very, very, very limited choice here. We move down into your IPA or your independent practice association. And this is the most common that we'll see out there under the HMO structure. Overall, you have four types of HMOs, which is your staff, your group, your network, and your IPA. But the two that we're going to be most concerned with for purposes of this class are going to be your staff and your IPAs. So under an HMO or a health maintenance organization, when we talk about this type of managed care plan, the details behind it are concerned with a plan where employees get to pick a physician from a provider panel and provide health coverage, and they provide health coverage with providers under contract. So an HMO is really differentiated from more of your traditional health insurance type plans because of this contract factor and the contracts that it has with these different providers. And through these contracts, they allow for premiums to be lower, which is really great for the patient because the healthcare providers have the advantage of having patients directed to them. So it's almost this pipeline of patients straight to this healthcare provider's business. The downside to this for the patient is that these contracts add these additional restrictions to members of this type of HMO. And that's how HMOs are able to go through and control costs of the plan because they control who their members see. Again, you know, they have this panel of providers that you can pick from, but you can only go to these providers if you want your HMO to pay for the services. And additionally, remember back to what we talked about with gatekeepers, a subscriber or a beneficiary or an enrollee, you'll hear them term different things, but anyone who buys into the HMO plan, they, again, cannot go see a specialist until they have a referral from their primary care provider because in an HMO model under this managed care plan, the primary care provider acts as a gatekeeper to control the utilization and control who the patient sees. So after HMO, one that a lot of you are probably more familiar with is the PPO. The PPO is the Preferred Provider Organization, and PPOs came about and were developed to work with beneficiaries enrolled in the plan to be able to go essentially outside of network. So it's less restrictive and you have more choice and you can get a discounted rate, but not as much as if you were to stay in network. So again, less restrictive, more choice. But it's set up in a manner that still offers a provider panel that you pick from, but it's modeled to be more of a preferred panel. And what I mean by that is the company is going to prefer you to go to this panel, but you're not required to. So like I said, you can go in network, you can go out of network, and it really allows for subscribers or enrollees or participants to have this level of freedom to choose the doctors and choose the hospitals that they want to go to. Now, you know, they have to have the understanding that the plan is only going to pay a certain amount and that they'll pay more if you go to their preferred panel, but it's not required. So obtaining services from doctors within this type of health insurance plan, the in-network providers is, again, going to result in the lower fees for those that are enrolled in the plan. But those out-of-network doctors are still covered. So the out-of-network can still participate, but the reimbursement method and the reimbursement amount is going to be just a little different. And coverage under this PPO requires more of an ongoing payment of premiums by policyholders to the managed care organization or to the insurance company. So let's take a look at the difference between when we talk about what's in network and what's out of network. Let's take a look at a little example I have put together that hopefully illustrates what it's like to have go to a provider that's in network versus a provider who is outside of the network or the non-PPO. So under the PPO, you've chosen a provider that's on the preferred panel. You have a $60 office visit, but because they are a preferred provider, they're on the panel, they're in the network of providers that will be seen under this type of plan, you get a $15 discount off your visit. So that's written off by the physician. So you're going to get a $45 reimbursement is what you've agreed to. Now you as the patient has a 20% copay, so you're going to pay $9, and the insurance is going to pay $36. So just as a review, the office charges $60 for the visit. They agree because they are on your preferred panel and they get a pipeline of patients to them that they'll take a $15 discount on any patient that's sent in network to them. So that this particular patient was in network, the provider agrees to the $15 discount. So overall, they're going to get reimbursed $45. Now you as the subscriber or the enrollee, again, have that $20 copay. You're going to pay $9, subtract that from your $45, and so this is what the insurance is going to pay is $36. Now this is for in-network. Now out of network is a little bit different. So if you as a subscriber, as an enrollee, decide to not go with somebody on the preferred panel, and let's say you have your doctor that you've seen for years, you recently changed insurance companies, they're no longer in network, but you don't want to change doctors, you want to continue to go to them. So they would be considered non-PPO. So they still offer the $60 for the visit, but because they are not in network and they've not agreed to any types of discount, you get no discount here. So that carries down to $60. What is allowed for reimbursement by the healthcare or by the healthcare insurer is $45. So you still have your $9 copay, your 20% copay, but the bill is still $60. So there's still $60 due. The insurance company, there's going to be the $15 difference in the reimbursement rate and the normal rate. So you get that from the 60 and the 45. So you are going to end up paying, as the insured person, you're going to end up paying $24 versus your $9 if you were to stay in network. You will be paying $24 because there was no discount negotiated with your non-network provider here. Again, I hope this is just a very simplistic example here. If you need some more explanation or want to talk about it a little more, again, feel free to email me at any time. And we can go over this example again. But just as a review for the non-PPO, you go see a doctor who is essentially out of network. They're going to charge the insurance company $60 for the visit. There's no discount. The insurance company is going to say $45 is what's allowed for that particular visit. You will pay your $9 copay off of that $45. But there's still a $15 visit between what was charged and what was allowed. So you add that in additional to what you made on your copay, and $24 will be what you end up paying as the insured, versus if you were to stay in network, you would have only been paying $9. So the last type of managed care plan that we're going to talk about is our point of service care plans. And this is going to be more of a hybrid between your HMO and your PPO. so this is more of a type of health insurance plan under managed care that's going to work to provide the benefits, different benefits depending on if you as the policyholder or you as the subscriber uses your in-network or your out-of-network healthcare providers. So with a point of service plan, like I said, it combines the features of an HMO and a PPO. And they only represent a very small share of the health insurance market. So most policyholders under managed care are either going to have HMOs or they're going to have PPOs. But under this one, you're going to have lower fees if you use that gatekeeper model, which is how it combines the characteristics of an HMO and a PPO. But again, this is a very small share of the health insurance market, which is why we're not going to spend too much time on it, because what you'll normally see is either your HMO or your PPO. So moving out of talking about different types of insurance plans and managed care, we're going to move into one of the last sections for this lecture, talking about coding aspects of reimbursement. So we have ICD codes. We used to be in ICD-9, but we moved to ICD-10 in late 2015, around October. And for those of you that are unfamiliar with ICD, what ICD stands for, first of all, is the International Classification of Diseases. So this is how hospitals, health systems code and classify mortality data. It's taken from death certificates. So ICD is considered the gold standard for diagnostic tool for healthcare management, for clinics, for epidemiology. So it's going to include the analysis, really, of general health situations for population groups. Excuse me. And you're going to see this a lot used by physicians. It's used a lot by nurses and other types of providers and healthcare managers to classify diseases, and then other healthcare problems that may need to be recorded on different types of healthcare or vital records, including more of your personal healthcare records with your facility or your provider. And again, one thing to note, they're going to consist of 3 to 5 digits overall. So you can start to see here 410 is a heart attack. The greater detail you're going to get, the longer the number is. So 410.0 is going to be a heart attack specific to the anterior wall. Now there's ones to the posterior. There's different types of classifications for heart attacks. But they work to specify more of these inpatient diagnoses. And again, we used to be under ICD-9. About 2 years ago, we moved up to ICD-10 in October 2015. And this is probably one of my favorite slides. I just threw this in there because it's just kind of, I don't know, it's funny to think about how ICD has grown over the past couple years, especially between ICD-9 and ICD-10. So between the two sets, the ICD codes grew about 19 times its previous volume. So in ICD-9, we had about 13,000 codes. When ICD-10 came out, we had 68,000 codes in ICD-10 that our providers now had to make themselves aware of. And I pulled out a couple silly examples. Like I said, this is just one of my favorite slides to talk about because I think some of these ICD codes are rather funny. And I've got a little video that'll go over them too. But some examples that I picked out, you have W55.21, which is bitten by a cow. That's an actual diagnosis. Another one, W220.2XD, walked into a lamppost. Sucked into a jet engine, hurt at the library, burned due to water skis on fire. I mean, some of the most ridiculous ICD codes I've ever seen. And again, I have a little short video I'm going to play real quick, but just gives you a background into ICD-10, some of the crazy different codes that have come out, and it's a good little kind of mental break here for us in the middle of this lecture. So again, you can see just a little bit of background into the change between ICD-9 and ICD-10. We had about a 19-fold increase between the two sets in terms of ICD codes. And, like I said, I just pulled out a couple that I thought were interesting to review over. So we may want to talk about, too, why there was such an increase between ICD-9 and ICD-10. And it's simply because with the more codes, medical providers, including disciplines like rehab therapists, they can now more accurately go in and document clinical information, including patient diagnosis. So this is going to lead to a greater opportunity for us to practice some evidence-based practice, give us better insight into optimizing more grouping and reimbursement processes, and really work to lessen the burden on clinicians to provide detailed supporting documentation. So aside from ICD-10 codes, we're going to have something called CPT codes. CPT codes are your current procedural terminology codes, and they are numbers that are going to be assigned to every task, every service that's provided by a medical practitioner or a medical provider to a patient. Including medical services, your surgical services, your diagnostic services. And then these codes are used by your insurers to really determine the amount of reimbursement that's going to be given back to your provider or your PCP, your medical provider, the amount they're going to receive by the insurer when they perform that particular service. So since everyone uses the same codes to mean the same thing, it really works to ensure that uniformity between reporting. So as CPT codes are developed, they're maintained and copyrighted by the American Medical Association, or the AMA. And as our environment in healthcare changes, new codes are going to be necessary, where old codes may be revised or they may even become obsolete and discarded. So thousands of codes are in use at the current moment, and they're updated annually. And you can see they're set up similar to ICD codes, but they include 5 digits. So you can have a code like 99211. It's going to be a simple office visit, where 99215 is going to be more of a complex office visit. So five digits for CPT. ICD codes have 3 to 5 digits. CPT codes you're going to find more in your outpatient, your physician office setting, where ICD you're going to find more in your inpatient setting. So the last type of coding that we're going to talk about is called your HCPCS. It's the Healthcare Common Procedure Coding System, but it's shortened to HCPCS in medical terminology. HCPCS is really an enhanced version that's used in particular by Medicare, Medicaid services. And it works to encompass everything that's not covered under CPT codes. So you're going to have your non-physician services. This is going to include more of your ambulance services. So if you have to take an ambulance to the hospital, to the emergency room, and then things like your DMEs, so your durable medical equipments, which are going to be things like prosthetic devices, things of that nature, are going to be covered under HCPCS. So there's 3 types of codes that are going to be used out in the field that you'll come into contact with. Going to be your ICD codes, which are mainly used in your inpatient setting, your CPT codes, which are going to be used more in your outpatient setting, your ambulatory care settings, and then your HCPCS codes, which are going to be things not covered under your CPT codes. And like I said, that's your non-physician services, your ambulance services, and durable medical equipment. So the last thing we're going to talk about is healthcare reform and insurance, and how things have changed in the environment, particularly in the healthcare setting, since the Affordable Care Act has gone through, and what changes that we're looking at and what changes we have already seen. So we have the Affordable Care Act that was put into law in 2010, and it was really designed to decrease the number of uninsured in the country. We had around 32 million Americans that needed help obtaining health insurance. Um, and so we had a lot of uninsured in the country at the time that the ACA was implemented. Though the full implementation was not expected to be complete until 2018, it's kind of left to be seen what's going to happen now with the recent election. So we're very uncertain still regarding what its full impact is going to be. Just a quick timeline of kind of where we've been and where we're going with the Affordable Care Act. So you can see 2010 is when a lot of people are familiar with the dependent coverage up until age 26. No maximum lifetime benefits went into effect. In 2011, free preventative care was included as part of healthcare reform. Insurance companies offering plans out on the marketplace had to include preventive care at no cost to their subscribers. Accountable care organizations started to come about around 2012. Of particular interest to those of you that will be going out into the healthcare field to practice as managers or leaders. Hospital readmission penalties started around 2012 too, so this goes back to value-based purchasing and the value-based purchasing program. And how hospitals are reimbursed now that we're getting away from fee-for-service and more into this value-based purchasing. 2003, we started to see bundled payments come into play. 2014 is when employer penalties started for those employers who did not offer health insurance to their employees. And then in 2018 is when the Cadillac tax for more of your high price plans is supposed to take effect. But as I said, the future is really uncertain, so it's just we're waiting to see what happens in terms of the Affordable Care Act, and what happens if it will be repealed, if it will stay in place, if it'll be modified, and what's going to happen there. So again, like I said, the overall goal of the Affordable Care Act was to help an estimated 32 million Americans across the country in helping them obtain some type of health care insurance. The ACA has two main mandates that a lot of people are very familiar with, and it's a hot point for political discussion. And those mandates are the individual mandate and the employer requirement. So the individual mandate simply stating, unless you meet a certain set of criteria, every citizen and legal resident in the United States must obtain some type of health care insurance. The individual mandate, again, says that all residents have to have that qualifying coverage. And that those without that coverage must pay a tax penalty. Now, those tax penalties are set up to either $695 per year up to a maximum of 3 times that amount, so you would be at around a little over $2,000 per family, or 2.5% of household income. So the greater of the two is what you would pay in your tax penalty there. There are some exemptions that are granted, and those would include things like your financial hardship, if you have religious objections, if you're an American Indian. Those without coverage for less than 3 months would not qualify for the tax penalty. Undocumented immigrants also would be a qualification or an exemption. Those incarcerated, serving time in prison, and those for who the lowest cost plan option exceeds 8% of their individual income, and those with incomes below the tax filing threshold. So there are a couple exemptions out there to the Affordable Care Act in terms of the individual mandate and what you are required to have. Now, we said there is the individual mandate, and we said there is the employer requirement, and more along the lines of the employer requirement. That requirement goes out to state that employers with 50 or more full-time employees that don't offer some type of health care coverage to at least one full-time employee, they're going to have a tax penalty per they're going to have a tax penalty of $2,000 per full-time employee, excluding the first 30 employees. So if you are a small business and you have 50 employees, you're going to paying $2,000 on 20 of your employees as a tax penalty. So this is going to require employers with more than 200 employees to automatically enroll their employees in a health insurance plan offered by their employer, and then employees have the option to opt out of that. But if you are an organization that has more than 200 employees, you have to automatically enroll employees in a health insurance plan and give them the option to opt out of that coverage should they choose to do that. Again, a little more on the employer requirements that we just covered. You can see 50 employees. With 200, you automatically have to enroll them in the program. Now, I thought this infographic was really great in explaining the triple aim and how the Affordable Care Act works to meet the triple aim of healthcare, which is cost, quality, and access. So, we have some different quality metrics here: access through the health insurance marketplace, and then some new consumer protection. And we have some benefits over here. We have new benefits for women, young adult coverage, how it's working to strengthen Medicare, and then working to bring some level of accountability to insurance companies. So a little bit of background into the Affordable Care Act if you're unfamiliar with it or still a little need some clarity on what's going on with it. But what I want to talk about is how we transition from the current to the future. So where we find ourselves now, in the past we were more in this first curve where traditionally we were fee-for-service, we're not reimbursed on quality, and we're paid more on volume. So we had a lot of fragmented care. We didn't have a lot of great communication or collaboration between facilities or between providers, and this was a great chance for standalone providers to really thrive in this type of marketplace. Now where we're going is more in curve 2. So we're moving more towards a value payment where we're paid on the quality of our patients, the quality of their outcomes and their indicators, the continuity of care, the alignment, how we're more concerned with making things efficient. We're working on utilization. We have alignment amongst physicians. Providers will hold the most risk for payment here because we are focusing on quality a lot more. But where we find ourselves now and why people can become so frustrated in the environment is we find ourselves in the straddle, what's called the straddle here. So we're seeing revenue drop. We're seeing, we're not getting a lot of reward for our quality because we're still learning how to do quality. We're still learning how to bring our metrics up. So we have, we're still paid on volume, but we still are kind of in this value-based purchasing model. It's kind of a mix between the two. But because we're being, mandated to move more towards a lot of more IT infrastructure, we have a lot more costs going towards IT infrastructure. And where that's hitting us is volume is decreasing. So we're not seeing a lot of people come into the hospital anymore. So we're caught in this straddle where our revenue is really, really dropping. But as we continue to work on these quality metrics and as components of the plan get put into place, we're going to find ourselves start climbing back up this second curve. Again, health reform, really big on value-based purchasing, and we're going to talk about that in the next slide. Reducing hospital-acquired infections or hospital-acquired conditions, HAIs or HACs, and talking about quality-based clinician compensation are going to be the main points for healthcare reform, or the main talking points for healthcare reform going forward. So when we talk about value-based purchasing, the graphic I have here just kind of shows how it's going to be implemented going through 2017. So we see back here in 2013 when value-based purchasing started, about 70% was based on the clinical process, and 30% based on patient experience. So your Press Ganey scores factored heavily into this. So as we moved into 2014, we see about 25% is going to be based on your outcome indicators now, so your quality of care. Clinical processes move down to 45%. Patient experience still stays at 30%. 2015, we start to see a split on efficiency in clinical processes, and then 30-30 split on outcomes and patient care. So you can see the outcomes piece starting to get larger as we move into 2016. Efficiency at 25%, clinical processes down to 10, and we have outcomes at 40%. So we see the domain weight is starting to shift as we start moving along through this implementation of the Affordable Care Act. And then we move into 2017 where only 5% is based on clinical processes. We have almost an even split between the rest in terms of a 25-25 split. With efficiency, safety starts to become a huge factor that we're looking at in 2017. Outcomes still a big piece of the pie here in terms of clinical outcomes and the outcomes of our patients. Are we seeing a lot of readmission rates? Are we seeing a lot of hospital-acquired infections, things like that? So what does this mean for finance and insurance? We're going to see, we have already, not in Tennessee, but in other states, we've seen an expansion of the Medicaid program. The hope is to have some price transparency here so that we can decrease the moral hazard and the adverse selection that we talked about at the beginning of this lecture. But we do expect to see a lot more high deductible healthcare plans. So what you'll hear people saying is the price of my health insurance is going up, and it is. Think back to when we talked about the community rating scheme and how we have to have a lot of low-risk people participating in the pool to compensate for the high-risk people. So premiums are going to go up. It's one thing that is expected. But we are going to have a new focus on chronic care, which is an emerging trend, unfortunately, that we're seeing amongst our patient population, simply because traditionally they have waited to come in and receive services because they didn't have health insurance, they couldn't afford the care at the time, and so their condition got to a point now where now they need more specialty type services. And again, too, with the Affordable Care Act, the individual mandate to have healthcare services unless you meet one of those exemptions that we talked about earlier. Fee-for-service payment cuts, like I said, we're moving away. Think back to when we talked about the two curves and the straddle. We're moving away from fee-for-service more into value-based purchasing, and this is the outline that was given in terms of when we can expect fee-for-service to be cut. So a reduction in our payment methodologies. So in 2013, we saw, very small start here. But by 2022, we're expecting a $415 billion cut in fee-for-service, moving more towards value-based purchasing, focusing more on quality, more on quality indicators, patient outcomes. And so what does that mean from a financial perspective? It means that finance and the finance department, those type of mechanisms are almost going to have to work hand in hand with a quality type department in the organization to work on reducing cost and maximizing efficiency so that a hospital or a healthcare organization can continue to maximize their revenue under the value-based purchasing model now that it's going to be based on safety measures and clinical or patient outcomes. This is all I have for the financial environment for Chapter 2 for this particular lecture. If you have any questions, feel free to email me, post to the discussion board, and I'll be happy to address those. And again, go through, pick out, like we did for the very first lecture, go through, pick out some questions that you think may be pertinent. We can talk about them next week, next time in class. Post those to the discussion board, points of interest to start working on your self-building study guide. and we can address any unclarities either in class or on the discussion board. Again, if you have any questions, please let me know. Thank you.